Just a little bit of background on Dr. Murali. He's an associate professor in the Department of Pediatrics at McMaster University, and he is a pediatric emergency medicine physician at the McMaster Children's Hospital. His academic work focuses on both essential newborn care and child injury prevention in low and middle income countries. He's been a member of the Global Neonatal Advisory Committee since 2018 and has served as a technical advisor for several projects, mainly in East Africa. His injury research focuses on examining factors associated with child passenger helmet and restraint use. This work is part of the Bloomberg Philanthropies Initiative for Global Road Safety, a multi-country project aiming to reduce road traffic injuries as well as fatalities. And I should add, I recently had the chance to hear Dr. Murali and have a coffee together in Quebec City. Dr. Murali was a keynote speaker there, and a very enlightening talk on how we can learn so much from toddlers, actually. And he recently wrote a book called Sleep Well, Take Risks, and Squish the Peas. So I would invite all of you to I haven't had the chance to read it yet, but I'm looking forward to that. So on a more global health topic, I now let Dr. Murali take the floor. Thank you.
Thank you. It's so nice to be here. I should also mention I'm a tea drinker, not a coffee drinker. So I just want to get that disclosure all the way. It's out of the way. It's been said already. I'm not talking about this at all today, but just in case, I just wanted to make sure it's out there because it is a commercially available product. So today I'm going to talk to you about something that's very close to my heart, and that's newborn mortality and ways we're going to solve that and continue to solve that. So we'll talk today about the major causes of newborn deaths worldwide and evidence-based systems to reduce those deaths. And then we're also going to discuss aspects of remote mentorship in newborn care, something we've been working on more recently, and how this can help providers in low and middle income countries. So let's start with the problem. I'm going to highlight a couple of problems here. Overall, this is a good news story, getting better, but it is still sad at the same time. So on the left side, you'll see the mortality rate. The yellow line is neonatal mortality, so children from 0 to 1 month of age. And the red line is children from 1 month of age to 5-year-olds. And so you can see the rates per 1,000 births very high in 1990 when we started collecting this data, and much lower now. And that's wonderful. We still have a long way to go. We need those lines to touch the x-axis or get very close to it like we have in Canada and other high-income countries. But I'll just highlight one important thing for you there. So you'll notice that the rate, the steepness of the slope is what we care about because that's the rate that it's decreasing. And you'll see the red line decreases or is much steeper than the yellow line, much shallower. And so we've been able to decrease under 5 deaths at a much faster rate than the yellow line, which is the neonatal deaths. And this also translates into the total number of deaths, which you can see on the right. So red again is the under 5 deaths and yellow is the neonatal deaths. Very significant progress in the under 5 deaths. Also significant progress in the neonatal deaths, but at a much lower pace. To the point where we're at 50% of all under 5 deaths being in the neonatal period. So the first month of life being the most vulnerable period, and where I choose to focus my attention for that reason. This just kind of shows you where those deaths are occurring. Lightest green is the lowest rates of neonatal mortality and darkest is the highest. And those numbers that you saw before were currently sitting at a world average about 17, but you can see some countries still are above 35. So 35 neonatal deaths per 1,000 births, which is quite sad. This shows that in a different way. This kind of shows the regions of where those deaths are occurring. And you can see on the y-axis where there's a lot of dots up higher. Those are the places with higher neonatal mortality. And those translate into Eastern and Southern Africa and the West and Central Africa regions who have the highest mortality in terms of region. But you'll see other standout places like that highest dot on this graph is in South Asia, and that's Pakistan, which has a rate approaching 40, which is very, very sad. This is another way of saying what I was talking about in the second slide. This is the annual change in neonatal mortality. So the deeper this bar is, the better, because we're seeing more of a decrease over time. And again, we have a much slower decrease in every single region for neonatal deaths compared to the under 5 deaths. And so these are all the causes of deaths of children under 5. And I'll just focus on the neonatal portion. So, like I said, it's nearly half of all deaths are the neonatal portion. And why are those deaths happening? They're happening for three major reasons: preterm birth complications, intrapartum related deaths, which we used to call birth asphyxia, and neonatal infections. And that's really what we're getting to and what we're going to focus on in my work and my group's work. This is perhaps one of the saddest slides, but we'll get to the more hopeful portion later. So 2.4 million newborn deaths per year. A huge proportion of them are preventable, at least 75%. Some estimates are even higher in the 80% range. And that translates into 6,700 newborn deaths per day. And so I'm sure most of you are familiar with the Sustainable Development Goals. And so there is a goal very specific in number 3, good health and well-being, that focuses on newborns. And so what we want to do by 2030 is to end preventable deaths of newborns and children under 5, with all countries aiming to reduce the neonatal mortality to at least as low as 12 per 1,000 live births, and under 5 mortality to at least as low as 25 per 1,000. And so for this talk, we're going to focus on the neonatal mortality. I showed you a couple of slides of where the problem is. This is the global average again. And so in 2015, we started at 19.7. 2020, we got it down a little bit to 18.2. We don't have 2025 data yet, so we're at 2023 data. We're at 17.3, but still there are major pockets of the world that are above the 25, 30, even above 35 range that we have a long way to go to meet that goal of getting it down to 12. So this is a program that was designed to specifically meet those needs of ending those deaths. And so this was created by the American Academy of Pediatrics by a team now known as GLONAC, which I'm a part of. This was started in 2010, and it had 3 different programs. So helping babies breathe to deal with intrapartum related deaths, essential care for every baby to deal with sepsis related deaths, and essential care for small babies to deal with preterm related deaths. What this course is a simulation-based, interactive, very fun course to teach newborn providers. And I say providers in a very general sense. Most of the world's newborns at birth are not taken care of by physicians. They're taken care of by midwives and nurses. And so this program really focuses on them. Like I said, it's simulation-based, it's small group, it's pictorial based, and it is actually a lot of fun to go through. And I hope sometime in your career you'll be able to interact with this doll or maybe even take the course. So this simulator is called Neonatally. Neonatally was developed by Laerdal Global Health in partnership with the AAP. And it's a really wonderful device. It's pretty low cost. It's about $60, $70 US. It can be filled with water or air. Very, very portable. You can see the bulbs on the side. It's a heart rate control, breathing control, and the heart rate shows up in the umbilical stump where you can feel it there. Has a detachable umbilical cord, which is useful for essential care for every baby when we talk about cord care. Has a suction device, and most importantly, has a bag and mask ventilator. And so that's one of the main things we're teaching in essential newborn care. The other great thing about this is that there's no other technology required. When you're teaching this, you're actually taking a flip chart, so no computer or anything, set up anywhere. You have mostly picture-based slides for people to see, and on the back there are instructor notes. The other one on the right is Preemie Natalie. So this is a similar simulator based on a premature baby, and it has the important function that it can be placed with the nasogastric tube. And so teaching that essential feeding skill is important. There's also another accessory called Mama Breast, which you can see on the bottom to teach participants when they're learning about this, how to position the baby properly for breastfeeding. And it also acts as a breast milk expressor to teach people how to do that and then cup feed the baby. So this course is fun because it's a very small group. As I mentioned, it's 6 people. Each pair of your 6 that you're teaching have one simulator between them, and they go through simulation scenarios, role-playing scenarios, and learn how to care for the baby. These are pictures, the bottom and the right, from a project that I did in Cambodia, and you can see how remote we went. And when I say remote, I mean really remote. This is a floating village in central Cambodia with no access to land. That is boat access only, and the people live off the fish and everything they catch from the lake that they live on. So now, very exciting. We've had this course since 2010. At the same time, in parallel, WHO has had their own essential newborn care course. And after many years of the data that the group has been putting out on essential newborn care, the WHO saw how practical, useful, fun this course was, and the data around decreasing neonatal mortality. And so now the WHO standard for teaching newborn providers is Essential Newborn Care Second Edition, which integrates all of the essential newborn care work that was done previously. So this is what it looks like. These are the algorithms. So you can see very straightforward picture-based for people who have lower literacy levels about what to do with a baby. And those 3 courses in the WHO version, most current version, have now been combined into 2 different courses, ENC1 and ENC2. And so on the top left, you can see that you get this baby. You decide if they're crying or not, fairly straightforward. If they're crying, they go down to the left side of the algorithm where they're getting kept warm with skin-to-skin contact, initiating breastfeeding, clamping and cutting the cord. Whereas if they're not crying, then we go into what we call the yellow zone and the golden minute. And the goal is by 1 minute to get that child breathing with bag and mask ventilation. The other one is Essential Care 2, which deals with all of the things we can do to prevent sepsis, as well as looking for danger signs and giving antibiotics when needed. There's a lot of data now with 16 years of experience with these programs, but I'll just talk about the most recent one. This was published in NEJM just last year. This is a study from Tanzania. It was a 3-year study in 30 different facilities. And the primary outcome that they were looking at was perinatal deaths, as well as deaths within the first 24 hours. And in this cohort, they had 277,000 babies, very significant. And so what they did was a few different things, which they called the Safer Births Bundle of Care. The first was the training innovations, what I've been talking about, these simulation-based training sessions. They had quality improvement, where they would look at some of their own metrics of what they wanted to improve, and we'll talk a little bit about how that's useful. They had sustainability and scalability, so really getting involvement from the hospital and the national level to ensure that the national level guidelines were incorporated. And then they had some clinical innovations where they were doing heart rate monitoring and making sure like all the equipment was functional, which is a very big problem sometimes. And so in this 3-year period, in the pre and post period where this intervention was started, they showed a perinatal death decrease from 15.3 to 12.5. And they also showed that neonatal deaths within 24 hours decreased from 6.4 to 3.9 per 1,000, which is very significant and really speaks to how many infections they were going to prevent, because a large portion of those babies are dying from sepsis. Okay, so I'm now going to talk about kind of the next step and the next phase of what we're trying to do in newborn health. So we know this course works. A lot of us have gone and taught the course. The problem is that over time, with any skills course, PALS, or anything that people are certified in, you lose knowledge and you lose skills over time. So how do we stay engaged with people, with newborn providers specifically over time? So there is a sparsity of data on this. This is one that I found, and this is on in-person mentorship, and we'll get to the remote mentorship later. This is a prospective cohort study in Rwanda with 25 different hospitals. They had 188 neonatal nurse mentees, and they used an observed checklist for all the things that the mentees were doing pre and post the mentorship sessions. And they found that the scores rose from about 42% to 75%. There weren't any neonatal outcomes recorded in this study. So the next step of this, of course, especially in the pandemic area, and this is a project that I worked on around 2020, is how do we get to remote mentorship? How can we assist the people that we've maybe trained in person, maybe trained remotely, to have continual mentorship? And so this is a project we did in cooperation with the AAP and UNICEF in three different countries, Kenya, Pakistan, and Tanzania. And what we did is we did a needs assessment, and the mentors that we were training chose different topics that they wanted to focus on. And so they wanted to focus on resuscitation, essential newborn care, prenatal counseling, and quality improvement. This is a link for anyone's interested. All of these sessions and this whole project was recorded, so that's all freely available online. And what was really important, I think, that came out of this project, some of our preliminary work, was some of the qualitative recommendations we got from people. So what they really enjoyed about this remote mentorship experience was the flexibility. We were able to reach a lot of people, even if they were in different locations, they were able to log in. We also made sure we've kept the simulation piece of this program, which is so key to it. And so we had some in-person facilitators as well, being able to set up neonatally and let them participate in that way. And that was really appreciated. Some of the recommendations we got from them were local buy-in. It is sometimes very challenging, although we have communicated with the hospitals at the district level as well as the regional level, to make sure that people who are needed in a clinical way, like we talked about earlier in the gap we have in healthcare providers, is hard to get them away for education. And so that's an ongoing challenge we deal with. Using existing structures, a lot of them felt motivated by getting credit hours, continuing medical education hours, nursing and physician. And so if we could build our education programs to facilitate them getting those credits, that would be really helpful for them. And then a consideration of technology needs. Of course, there are different pockets where, of course, the internet is not as good. And then really being able to, perhaps in future grants, provide money for data packages would be helpful for them. So now we'll just talk about our latest project that we are doing. This is a essential newborn care project in Tanzania for ECHO, so extended care for healthcare outcomes. We started this in 2023. We ran it till about the middle of last year. And what we did is we did a train the trainer approach. So this project was completely remote. We did all of our training remotely and all of our mentorship remotely. We initially trained, and I'll get to this, a number of people that were going to be the master trainers in each of the hospitals. And then they went on to train all of the providers in their hospitals. And then we met with them monthly, and we did a couple of different checks for them. We have a knowledge check that's built into Essential Newborn Care. And there's also some OSCEs, objective structured clinical evaluations, that we were able to monitor over time as well. So these are the 6 regions we worked in. There was 3 of us as technical advisors when we were in 3 different countries. We trained 44 in-country facilitators and met with them monthly for the mentorship. And then they themselves trained an additional 92 healthcare workers in their own hospitals. The AAP has now developed a program to specifically focus on mentorship called CRISP, which is customized as the first letter of that acronym. And so we did a needs assessment with them, and they really wanted to focus on facilitation skills and specifically QI. So a lot of our mentorship for this program was focused on quality improvement. And this algorithm, this is just an interesting paper, but this algorithm really lends itself well to QI interventions. So you can see we're trying to get to outcome measures. We're trying to decrease, intrapartum related deaths due to birth asphyxia. We have process measures of what we're going to do. And then the algorithm, you can see the bottom right, for example. If we want to get to intrapartum related deaths, we can pick any of those sections and focus on one of them. So that bag and mask ventilation one, it's kind of tiny. It says number of non-breathing infants that received a BMV within the golden minute, very specific to the number of non-breathing infants born in facility. And so this is the kind of thing we would be training people to do and record monitor over time, and try to get those numbers up so we could affect the outcome measures over time. This is what our sessions look like. We have our six centers there. So very hands-on. You can see everyone has their simulator, and we had discussions on cases as well as question and answer period, and myself and one of my colleagues who works in the US. The other great thing about this project is we had something called Neonatally Live. So Neonatally Live is like that simulator that I showed you earlier, the basic one, but it's hooked up to a tablet and also has a remote internet connection. This is not an inexpensive one, but just something we've just started to use as we try to do more remote training. And this can give simulation scenarios that people follow along with and gives them feedback on what they've done. And all of that information is also fed back to us. So it's a very exciting, very preliminary. What was great about this project is this is very common that, you do a baseline. We have the post training data, whether it's knowledge or OSCE scores. And then we have some X amount of time that it goes by, and then we reevaluate. And inevitably, if there's nothing been done in between, those scores are lower, usually than at least the post training, but maybe a little bit above the baseline. What we're able to show with this project is that over 8 to 9 months, with this continuous mentorship, we're able to keep those scores up, both skills and knowledge. We haven't published this yet. We're just going through all of the qualitative information we have, but we have some of the information I wanted to share. So 80% agreed that remote mentorship helped translate essential newborn care 1 knowledge into sustained practice, increased knowledge and skills, and 100% indicated that they would recommend essential newborn care training and mentorship to others. And this is what our master trainers have had to say. So definitely reinforced their own learning, building our capacity. They were able to practice all the skills they were learning on a continuous basis. And then identifying challenges. So mentorship helped me evaluate my direction, plan what I was going to do, self-evaluate whether what I taught was actually reaching the learners effectively. Because a lot of what we did was, as I mentioned, the QI projects, but also the evaluation piece of this. We involved the Ministry of Health in this project and the local East African and South African Society of Midwives and Nurses. And we have some of their data as well. So they found this very accessible, like having access to a mentor in a different country on a regular basis was really helpful for them. And they also saw the accountability, like some of their colleagues doing something in a certain way and adopting it was helpful for them. Of course, there's always challenges. Some of the challenges we've come up with so far in this project is equipment. That Neonatally Live, although it's a wonderful thing, it's very hard to start something brand new, both for us and for them, while doing it all remotely. So we're still working out some of the kinks of that. The logistics, we had people in 4 different time zones, so Tanzania, but then 3 of us in 3 different time zones, so really challenging to get a time that worked, but we did our best with that. And then structural, they were actually very happy that we were focusing on the regional hospitals, but they want us to go to the district hospitals because sometimes if the babies need to get transferred, the people at the district hospital would question their care and might not be aligned with what we were teaching. And so we need to be focusing on district hospitals as well as regional hospitals, which is where the most of the mortality is. Okay, so hopefully that provided you with a good overview of the problem of neonatal deaths worldwide, some of the things we can do with simulation-based training, QI initiatives, and continuous mentorship. If any of you are interested in this program, I just have the QR code up right now. We run sessions to get trained in this program at least a couple of times a year. We've had them in Canada as well. We had one in Vancouver not too long ago at the CPS meeting and at McMaster. It's a great way to really have a skill that is completely portable anywhere. You did not have to be a pediatrician. You did not have to be an MD. Like I said, a lot of our participants and trainers are nurses and midwives, as well as medical students. And then one more plug. This is a grant that applies to anything in child health. Does not have to be newborn, what I talked about. Just want people to know about it. If there's anything in child health that you're working on in any LMIC, there is a grant that the AAP provides. It's a small grant. It's 2,500 US a year for 3 years, but it's for any like seed project that you really want to start. It has to come from the LMIC country and facilitator there, but it's so helpful to have someone from North America assisting people with writing this short grant and getting it. I helped my colleagues in Cambodia get one for the essential newborn care work we did, and it's always very helpful and hopefully makes it sustainable for them. So thank you very much. I can answer some questions. That's a little bit more about me. I spend a lot of time on LinkedIn, and I have a website which has a little bit more about me and my global health work, as well as a video of some of the work we did in Cambodia.